Welcome. My name is Zarowski, and I'm the sexual health clinician at the Prostate Cancer Supportive Care Program. Today, we're going to actually do a presentation that focuses on managing the impact of prostate cancer treatments on sexual function and intimacy. First off, I wanted to take the time actually to applaud you for actually coming and joining me to watch this presentation today, because I understand, whether you're going through prostate cancer or even bladder cancer, because this presentation also pertains to bladder cancer, this could be a time of many changes, many challenges, whether you're going through emotional changes, physical changes, or psychological changes. Purpose behind our presentation is to provide you with knowledge, because knowledge actually helps to empower you as you actually go through your cancer journey. In order for us to be here, we actually have to be grateful to the different funders that we had to support our program, because without the individuals that you see or the organizations that you see before you, we would not be here to support you. So thinking about the session today, what we're going to do is we're going to talk about the Prostate Cancer Supportive Care Program. We're going to talk about the sexual health program and the clinic. We're going to look at areas around sexuality and intimacy. We're going to look at what maybe normal sexual function looks like. Also, we're going to talk about the impact of the cancer treatments on sexual function, and of course, looking at how we might manage some of those outcomes. So here's a slide just talking a little bit about our program. Basically we offer education sessions, clinical support appointments, and have a research component in our program to better understand the needs and treatment strategies for prostate cancer survivors and their partners, and also bladder cancer survivors as well. We actually have 7 modules in our program, and basically these modules actually, most of them offer education sessions on a monthly basis. And they also have clinic appointments associated with them as well. If there's any of these modules that you're interested in, you can contact your coordinator to ask for an appointment. Basically, when you think about where you are in your journey, maybe some of these modules might not be relevant at this point, but at any time, if you have any curiosities about the modules, you can actually, again, talk to our coordinator about that. So when we think about our module number 2, our sexual health program and clinic, the primary goal is to provide education, supportive care, medical and surgical therapy to enhance not only sexual functioning, but intimacy and quality of life as well. This is actually a little snapshot of our team, and basically we're housed in Vancouver, but we can provide support all across the province. When we think about the clinical care modules, we're actually in the process of combining 2 different components. First of all, we have our sexual health clinic. Here, we actually support patients, and if you happen to be have a partner, we support you over maybe a 1 to 2 year period. This can include maybe up to 7 appointments. Basically, these appointments can be done virtually, in person, or via the telephone. During the appointments, we actually look at what's been happening with you in regards to the prostate cancer treatments, what are the different sexual consequences that have occurred from there, and what are the ways of sort of managing those consequences. The Share Clinic is actually a virtual online course. Basically, with the Share Clinic is that you would actually get a code that you can enroll into the Share Clinic. You would actually put in information about your experience, whether or not you're partnered, what type of treatment that you had, and basically it will customize an educational course for you. I am actually the health coach associated with the Share Clinic, and I actually support anybody in British Columbia. One thing about the Share Clinic that I do need to say is that it is structured specifically for individuals going through the prostate cancer journey. This is actually a snapshot of the platform of the Share Clinic. You see on the left-hand side, there's there's a dashboard which talks about maybe activities that are scheduled for that day. There's trackers. There's also the circle of care, who's involved in your care. There's care plans. Again, those are the educational modules that we have. And then also There's a health library that you can access as well. Also, you can communicate with the health coach, and this is actually just demonstrating that. So let's create some perspective. So you probably heard that treatment for prostate cancer or bladder cancer can affect your erectile functioning. This can impact your sexual functioning, how you feel as a sexual person, and intimacy with the partner. A lot of this information might seem specific for partners, but information can also pertain to individuals who are single or in the process of looking to get a new partner. Okay, so when we move forward with this, we're going to create some perspective around intimacy and sexual functioning. So let's take a closer look at sexuality and many components of that. When we think about sex, sex is something that we do, and sexuality is the essence of who we are as unique individuals. It's how we express ourselves and what brings us joy and pleasure. It includes all those feelings, attitudes, and behaviors that contribute to a person's sense of self. This is actually the wheel of sexuality, and it shows the diversity of sexuality, including elements of biology, psychology, and sociology, or actually the different types of influences that come from those different areas. So what's important is that you want to look at how your cancer experience has impacted any of these areas, because that's going to actually help you as you maneuver through what we call the sexual adaptation process. At the very top of this wheel of sexuality is the values and beliefs. And this is something that's really important to keep in mind, because this is actually what guides us in regards to our sexual behavior, or even how we feel about ourselves as sexual individuals. So we think of intimacy as an umbrella term for affectionate or loving personal relationship with another person. It's that closeness that you feel with someone. There are multiple dimensions that make up intimacy, and it's powerful to share the intimacy with another person. So I actually remember doing a workshop where we were able to identify up to 41 different types of intimacies. Today, we're just going to talk about 4 primary ones, but it is important to remember that there are more types of dimensions of intimacy beyond what we're going to talk about today. So the first one is intellectual intimacy. This is kind of the rich meeting of the minds. They are the interests, thoughts, ideas, and connection on values. Next, what we see is experiential intimacy or relational intimacy. This is the closeness and activities that you do together, that you enjoy doing together. And then, of course, we have the sexual intimacy, which are practices of sexual relationship with a partner. And then we have emotional intimacy. Emotional intimacy is how you support each other, being vulnerable together, that feelings of closeness and trust. You see that these intimacy bubbles are all equal and balanced together. But what we see is that a lot of times, depending on the situation, there might be one intimacy dimension that's more significant or important. So it's really important to check in, with your partner about what is important in regards to the different dimensions of intimacy. Now we're going to talk about the sexual response cycle. And there's lots of different theories that talk about this. This is actually kind of like a basic theory. So usually what happens is most people will start with having sexual desire or arousal. This is where you become sexually excited. Next, we see physiological responses in the body. One example is the development of an erection. After the erection, you may arrive at an orgasm or climax, which is usually coupled with ejaculation. And then the last part of the sexual response cycle is the resolution or refractory phase. This is where the penis becomes flaccid or relaxed, and another orgasm or erection is not possible for a period of time. So we're going to go through each of these areas and find out different types of elements that might affect these different stages of the sexual response cycle. So when we think about sexual arousal and desire, is that, a lot of these are very common sense kind of variables. If you're stressed or anxious or tired, to be in the mood to be sexual is definitely decreased. Also, things like how you're feeling about your body, whether or not there's pain, or even certain medications can affect that kind of sexual appetite as well, including the hormone testosterone. When we think about the next section, which is focusing on erection, again, certain medications can affect the ability to kind of create or maintain erections. Different types of medical conditions, like whether or not a person has, like, say, diabetes or cardiovascular disease, even lifestyle factors. Is a person, do they smoke? Are they consuming excessive amounts of alcohol? And then, of course, the different types of treatments for the cancer can affect erections. And then, of course, those psychological or emotional variables as well. It's going to be nice and relaxed here. I'm going to take a little sip of my tea as I continue to talk. So when we think about factors affecting orgasm and ejaculation, it can be related to the type of stimulation a person is experiencing, whether or not there's erectile dysfunction, again, those treatments for the cancer, also those emotional types of stressors that can affect the ability to appreciate or relax to be orgasmic. And then again, those medications can also affect. So again, we see some consistency with the different types of variables that can affect any of the stages of the sexual response cycle. When we think about the last stage, we know that age is a big variable. The older a person is, that more that stage is going to be affected. It'll take longer time before the person can be sexual again. Again, looking at, if there's, again, those emotional variables, or again, medications as well. So now let's talk about the actual erection, okay? So basically we know that erections occur from thinking sexual thoughts or sexual touch, or even in our sleep. And actually, we know that all of the erections need a special signal that's transmitted from the spinal cord to the penis through a special nerve. And that nerve is actually called the cavernosal nerve. You can see that there's a cross section. Okay, upon receiving that signal from the nerve, there's spaces inside the penis. They actually begin to relax. Then blood flow comes into the penis, and that is actually what stimulates the development of the erection. You see the little diagrams in the bottom right-hand corner. The diagram on the left actually is showing a penis that is relaxed. Right? There's actually 3 tubes in the penis. 2 of them are called the corpus cavernosum, those are the erectile bodies, and the other tube houses the urethra. It's called the spongiosum. The diagram on the right actually shows those little spaces. It looks like Swiss cheese. The little spaces are called sinusoids, and they're surrounded by smooth muscle and endothelial tissue. When they relax and open, that's when the blood comes into the penis to create the erection. And actually, I wanted to make a comment about those sleep erections. And I always ask whether or not people understand why men actually have erections during the night. And I'm actually quite jealous about this, because basically what happens, the erections at night is a biological process. And there's a signal that's created that the man will have maybe 3 to 6 erections during the night. They're not sexually induced. Again, it's the way how the body keeps the penis healthy. I mean, I wish when I was sleeping that my abs worked out, but that doesn't happen. Okay. So when we think about erectile dysfunction, there's actually 3 kinds of mechanisms that can affect erections. And first off, when we think about the nerves, if the nerves are actually damaged or become injured, then they're not able to send out that signal. Next thing what we see is that there can be damage to the actual muscle. And then again, when the muscle is not as healthy or becomes fibrotic, it's not able to sort of put enough pressure in the penis to actually maintain erections. And then the last component, what we see is compromised blood flow. So let's look at these areas a little bit more closely. Okay, first off, I wanted to demonstrate where those cavernosal nerves are. And as you can see, they come down from the spinal cord and they actually wrap behind the bladder, and they kind of like are a mesh of nerves that are very close to the prostate gland, right? So again, when we think about cavernosal nerve injury, we'll talk about prostatectomy first. So again, with prostatectomy, the goal is, the surgeon's goal is actually to get rid of that cancer. So if possible, depending on the characteristics of the cancer, the surgeon might be able to do what is called a nerve sparing procedure. So a nerve sparing procedure, it could be unilateral, it could be bilateral, or there could be no nerve spared. But if there is nerve sparing done, what happens is that these nerves are very, very sensitive. They don't like to be looked at, they don't like to be touched, they don't like to be, exposed to heat, any of those kind of things. And that's what happens in surgery. So when that happens, the nerves actually go into kind of like a shock phase called neuropraxia. And that shock phase can last quite a long time. So when the nerves are in that shock phase, they're not sending out any kind of signal. So if there's no signals, then there's no erections. So when we think about external beam radiation, basically what's happening is radiation is destroying the DNA in the cells, so killing those cancer cells. We focus on the prostate gland. That's where that little red circle is, showing 95% of the radiation is focused there. But you can also see that there is radiation that's kind of going out from that area. So again, that can be causing damage to those nerves that are controlling the erections. Same with brachytherapy, which is actually the implant of little tiny pellets into the prostate gland. Again, there can be radiation emitted away from the prostate gland, again, affecting those nerves. So when we think about cavernosal muscle fibrosis, that's kind of like, where the tissue is not as flexible, is that we know that prostate treatment can actually cause the penis muscle to become less healthy. So when we think about the penis muscle, around the penis muscle, there's actually a layer called the tunica, which is actually kind of like saran wrap. So what happens is that when the penis actually fills with blood, it actually begins to put compression against the blood vessels, against the firm tunica. And when that happens, that's actually how the erection is maintained. When the tissue becomes more fibrotic, then it won't have the ability to expand against the tunica. And this will prevent the blood from staying in the penis. And this is what will lead to what we call venous leak. Okay, so that's the inability to keep the blood inside the penis. Okay, so analogy that we kind of use is if you think about a bicycle tire, and that there's a valve that's just not working properly. It doesn't matter how much air you put in that tire, it is not going to get firm. So this is why it's really important that we exercise the tissue in the penis so to prevent that fibrosis from developing. Okay. And then the other thing that we know is the compromised blood flow. So in order to form a good rigid erection, we need to have good flow. But prostate cancer can cause damage to the blood vessels, or even cause some narrowing to the blood vessels. So when this happens, the limited blood flow will again affect the ability to create the erection. Sometimes what we see over time is that compromised arterial blood flow may be reversible depending on the type of damage or the treatment. So these next two slides are going to talk about the timing of erectile dysfunction when comparing prostatectomy, which is shown in red, radiation therapy, which is shown in yellow, and active monitoring, which is shown in blue. For active monitoring or active surveillance, this is where your doctors decide to actively monitor the prostate cancer so there's no treatment. You'll notice that there's a decline in function due to aging. Regardless if you have treatment or not, there's age-related decline in erectile functioning. For surgery, there is immediate decline in function within the first 6 months and a slow improvement over 2 to 4 years. So that improvement over 2 and 4 years, that's how long it might take for those nerves to recover. For radiation, there's some immediate decline in function within the first 6 months due to inflammation, and then this can improve over the next 6 to 12 months post-treatment, and then flows the natural rate of natural decline. Okay, at about 36 months, the rate of decline in erectile function is very similar between no treatment and the other treatments. So again, we know that even without treatment, there is going to be a natural decline in the ability to create erections. This is actually showing the timing of erectile dysfunction with brachytherapy. The top graph shows men with normal erectile function before starting treatment, and the bottom graph shows men with ED or erectile dysfunction before starting treatment. Within each graph, you'll see 2 lines for each time points. The line on the left is men on androgen deprivation therapy or ADT, and on the right, men are not on ADT. So let's start by looking at men who received brachytherapy with ADT. We've added a blue line to show the general trend. The most significant decrease in erectile function is within 1 to 5 months after treatment. Looking at men who only receive brachytherapy with the red line that you see here, there is some decline in function within the first 1 to 5 months and then continuous decline even following the natural rate of decline that we see. The most important factor to keep in mind here is the age of the time of treatment. The younger the person is, the better recovery. And erectile function at the time of treatment, if there is dysfunction or challenges with creating those erections, then there's going to be more challenges with how the body's going to heal. And remember, your body has the final say of how it's going to heal from any of these kind of treatments. The next couple of slides, we're going to look at the impact on the different dimensions of sexual function. So for active surveillance, what we see is, remember when we talked about the sexual response cycle and variables that can affect the areas, is that we know that if there is anxiety, that's actually going to affect the ability to maybe have erections or even be orgasmic. When we think about ejaculation or anatomy changes to the penis or even urinary bowel changes, with active surveillance, we really don't see any changes with that. With prostatectomy, what we see is that there's change is immediate because we know that the nerves are affected right during the surgery, okay? With sexual drive, it's not really affected directly, but again, when you think about the early stages after having surgery, you're not probably wanting to be sexual, because especially if you have a catheter in place. But over time, you know, that desire would begin to come back. When we think about erectile dysfunction, we know that it's immediate because, again, the nerves are affected, whether they're spared or not. We know with orgasm, there can be some changes initially. What we see when a person's beginning to explore their sexual response after they've had surgery, there might be some discomfort just because, you know, everything's, you know, kind of healing in that pelvic area. We have the 40-40-20 scenario. This is the experience that I've had. So 40% of men will come back and tell me, you know what, the orgasm's pretty much the same. 40% will say, you know what, it's different, but it's still pleasurable. And then there's 20% of men will say that, wow, my orgasms, I'm over the moon with them. In fact, some men have learned to be learn the secrets of women, where they become multi-orgasmic. So with ejaculation, when we think about the prostate gland and the seminal vesicles, is that those are responsible for creating about 90% of the fluid in the ejaculate. So again, when the prostate is removed, the seminal vesicles are also removed. So that's why there's no ejaculation. The other thing that we see is actually, one of the things I wanted to say about orgasm and ejaculation, sometimes people, they think that they're one of the same, but they're actually not. They're actually two different functions. So if a man feels that, well, I'm no longer ejaculating, I cannot be orgasmic, that's not the case. The same is if there's no erection, people or men believe that they can't be orgasmic, but the nerves that control erections, the nerves that control orgasms, they're different nerves. So even without an erection, a man can still be orgasmic. Anatomical changes, it's possible after prostatectomy. What we see is that there could be like a shortening of the penis. We don't know exactly what's causing this. That could be related to scar tissue. There could be related increased tone in the pelvic area, drawing the penis in. Also, when the prostate gland is removed, you know, they actually bring down the bladder neck to reconnect with the urethra, because the urethra, the P tube, actually runs through the prostate gland. So sometimes there could be a pulling up that happens with that. A lot of men will talk about that, you know, after maybe a year or so after prostatectomy, the appearance of the genitals look almost like it did before the surgery. So urinary issues, we know that the surgery will disrupt part of the sphincters that control the outflow of urine. A lot of times after prostatectomy, men will experience what is known as almost like a stress incontinence. So when there's increased pressure in the abdominal area, there could be urine leakage. So when you laugh or sneeze or pick up something heavy, right? The other thing that can happen is there can be urine leakage during sexual arousal or during orgasm. So that if you have urine leakage during orgasm, that's known as climacturia. A lot of men or a lot of couples worry about what happens if urine gets on or in my partner. Well, basically, urine is considered to be sterile. So if it happens to get involved or into the partner or on the partner, unless there's any active infection, it's not going to cause a risk or pose a risk for that partner. With bowel issues, we don't really see any changes, after prostatectomy, and there's no other areas that we see that there's concern with as well. When we think about the different types of radiation therapy, is that we know that right after treatment there usually is changes that are happening with how the body can function sexually, right? Basically, we know that with sexual drive, especially if there's androgen deprivation therapy that's given, that's a hormone therapy, there could be a decrease in the drive. When we think about erectile function, usually what we see is that, again, right after treatment, there can be a change and then a slow decline, maybe after 6 months, or even longer. When we think about orgasm, sometimes the men will report that it takes longer or more stimulation to get to that orgasmic mountain, right? So, again, looking at different types of stimulation might be something a little bit better. And that's something that we would talk about, in our appointments. We think about ejaculation. Again, the radiation is affecting how the prostate gland is working, and so over time, as the radiation is doing its job, the amount to ejaculate slowly decreases. With brachytherapy, sometimes in the beginning, just after treatment, there might be a little bit of blood that's noted in the ejaculate. In regards to changes with the anatomy of the penis, it's not really that common with radiation. And with urinary issues, a little bit different from prostatectomy. So, we think about, where the bladder is situated close to the prostate gland, it actually can be affected by the radiation. So there could be increased frequency, increased urgency that is noted. Also, if there's any inflammation in the area, that actually might impede the ability for the urine to come out of the body, so causing retention. Right. So again, it's really important to monitor that. So if you notice that your flow is not as strong before, there might be a little bit of narrowing with the urethra. There might be some scar tissue that's beginning to develop. So there might be a little bit of surgical dilation that's needed to kind of open up that urethra. The other thing with brachytherapy is that, again, in the beginning stages, there might be some blood that's noted in the urine as well. With bowels, because again, the proximity of the rectum to the prostate gland, we see that there can be changes with bowel habits as well. What we might see is that there could be a change in the characteristics of the stool. There might be more diarrhea. There could be inflammation in the rectum called proctitis, which can lead to discomfort, pain, bleeding as well. Over time, and there's other types of treatments that could be helpful for these kind of side effects. Also, dietary factors are important to keep in mind. Like, for instance, an example might be having a low fiber diet, especially when you have these kind of symptoms, right? The other potential effects we might see is there could be skin irritations from the radiation, and also a lot of times after brachytherapy, there's a recovery period, because it is there can be some discomfort with how those pellets are actually inserted into the prostate gland. When we think about androgen deprivation therapy, what we find here is that the purpose of the androgen deprivation therapy is to reduce the amount of testosterone in the body. So testosterone is one of those hormones that actually kind of gives us our zing in life, right? So as it begins to go down, that's where we see more of those kinds of side effects. So decrease in sexual drive, changes with ability to create or maintain erections, decrease intensity of the orgasm, or more challenges getting to up that orgasmic plateau. Again, volume is decreased. We see more changes with penile anatomy. The penis might become smaller, shorter, thinner. The testicles might actually become smaller as well. In regards to bowel and bladder changes. We don't really see that with androgen deprivation therapy, but we can see things like there could be weight gain, there could be loss of body hair, there could be the development of breast tissue, there could be fatigue, hot flashes, changes to cardiovascular health. So there's lots of different side effects associated with androgen deprivation therapy. Again, these are some of the things that can impact, feelings, a sense of masculinity, all those kinds of situations. So what we do say, it is important that if you are going to be going on androgen deprivation therapy, or you are on androgen deprivation therapy, it's important that you connect with our module number 4, so you can learn how to manage some of those side effects. Okay. So we'll think about, as kind of in review, the factors that are impacting post-treatment dysfunction is what was happening before the cancer treatment was initiated. Was there some ED before? How old that person is? Are there any kind of medical conditions that can compromise sexual functioning, such as diabetes or cardiovascular disease? What type of treatment was given? Whether or not there was actually nerve sparing that was conducted as well. So the key thing to remember is that, you can have a good sex life after prostate cancer treatment. In fact, I've been in this role since 2013, and I've worked with lots of, whether they're single or in partnered situations, and there's, been really positive outcomes, but it takes a lot of time and patience. And we're going to talk more about that as well. The other thing that I say is that if you're in a partner situation, if you've been in a partner situation a very long time, what I've seen is that a lot of couples will have a pattern of how they're being sexual. So having a pattern, there's nothing wrong with that. I mean, it's something that's familiar, provides pleasure, but cancer treatments will disrupt that pattern. So how I look at this is it actually creates an opportunity to redesign your sexual life. For a lot of people, they might be really focused on their sexual activity, not really thinking about, the diversity of sexual activity. So this is opportunity to try, different things. So remember when we looked at that wheel of sexuality, and I was talking about values and beliefs. So values and beliefs are actually directed by different influences in our society. And one of those things are societal myths. But let's talk about some of those myths. So one of them is people with health challenges have no interest in sex. That's not true. In fact, a lot of times as we all begin to age, we tend to have some kind of health challenges, and we are still being sexual, right? Male orgasm requires an erection. I already said something about this earlier, is that orgasms and the nerves used to control erections are different. And so again, without an erection, orgasms are still possible. Sex is for young people. Wow, I'm glad that this isn't a reality. In fact, I remember doing an education session very similar to this, and John came up to me after the session. He says, Chris, I really love sex. I love being a sexual person. I feel very connected with myself. I feel so connected to my partner, but I know I should not be sexual anymore because I'm 83. Wow, we changed that. Good sex requires orgasm. Orgasms are great, but it's not a requirement for good sex. In fact, there's lots of different pleasure sensations that we experience, when we go through our sexual journey. Sex education is for disease prevention only. Well, you're here, and so that's debunking that myth. Sex should be spontaneous with no planning, no talking. This is a tough one. Is that, again, like even before having cancer treatment, there was some thinking about and some talking, a little bit of planning. Maybe not a lot of talking. Some couples don't talk at all. Some couples are really good at talking. It is true after having cancer treatment that there is more talking, and it's not as spontaneous as it was before. Sex means sexual intercourse. Some couples, that's what they primarily focus on, but there is other ways of enjoying sexual pleasure. And that's something that we can talk about in our appointments as well. And here, men should initiate sexual activities. Well, again, men don't have to be the initiator, but sometimes in a partner situation, they might be the initiator. So if a man is actually on androgen deprivation therapy, there's nothing on the radar. So again, if you need to talk with your partner about, you may be setting up dedicated time. So again, thinking about these different myths and realizing whether or not they are part of your value or belief systems. If they are, that's actually going to cause some challenges, as you move forward through what we call the sexual adaptation process. So, all right. So how to manage the side effects and or sexual consequences. So what do we do? So some of the approaches are, communication. This is a really important one, right? Maybe even refocusing your intimacy with your partner, going through that sexual adaptation process, looking at maybe possible therapies for managing the changes with erections, work with a sexual health clinician in our program, right? Okay, so let's think about communication and intimacy. This is the most important way to improve your connection with sexual functioning is through communication, right? By maintaining open dialogue, you can ensure that each of you are satisfied with your sexual relationship together and are on the same page. So why talk? So basically, as I said, it's the best way to enhance your sexual functioning. Sharing your thoughts and feelings can help you both process any of the changes, right? We like to say prostate cancer is a couple's disease, as prostate cancer treatment can affect the partner just as much as the person with cancer. This is why it's important to ask your partner how they're feeling. We often think we know a person, we think we know what they're thinking, but again, it's important to check in. I worked with a couple that, John was on active surveillance for, I think, about 2.5 years before he had his prostatectomy. During that time, his wife was stressed out. And once he had the prostate removed, she goes, John, I'm so glad that you finally had treatment. These last 2.5 years have been just devastating for me. Well, again, it's important that, paying attention to what the partner is feeling or experiencing in that situation. So talking is very, very important. So then it's like the next step is, well, how do you actually begin to talk, right? Well, first off, you think about what's important for yourself and what's important for your partner, right? Discuss both your thoughts and how you can make changes, right? Being clear, honest, open about your likes and dislikes is important, and also paying attention to your partner's responses and acknowledge their feelings, right? Sometimes it's really challenging to actually have that conversation. So by actually writing down your thoughts, it actually gives a little bit more clarity about your perspective and makes it easier to communicate that with the partner. And then also, if there's still some challenges with having that communication, then think about, talking to our clinical counselor or seeing a relationship counselor or looking, talking to a sex therapist at all as well. Again, these individuals, they are facilitators with communication, right? So again, when we think about, intimacy, remember we had those bubbles that we talked about earlier. So again, thinking about maybe refocusing the intimacy. A lot of couples that I've worked with, over time, they've come back and they've actually focused on other types of intimacy. And they even shared with me that the different dimensions of intimacy are much better in their relationship. So when we think about, we'll be talking lots about partners and stuff, but being sexual, if you're single, being sexually active or feeling attracted is just as important, right? The same treatments and resources are available for single men, whether you want to be able to masturbate, have sex, or start a new relationship. All this information applies, and we actually encourage single men to actually come to our program or come in for an appointment. We know if you are starting a new relationship, this can be challenging, to share your cancer experience. We find that, being honest, keeping things simple is really important. The other thing that we find is that, even having a conversation with a trusted friend, like doing some role playing, to practice how you might talk to a new partner about the different consequences that you've experienced from your cancer treatment. Yeah, so prostate cancer can cause changes with your sexual life that requires adaptation. The process of this process actually can be quite complex and warrants the need to apply the principles of acceptance, flexibility, patience, and persistence, right? So with acceptance is kind of understanding the different consequences, understanding why they have occurred, and more importantly, understanding how to cope with those consequences. This also might include, a grieving process with the changes or the losses that you experience. Flexibility this is about keeping an open mind. And flexibility is also looking at your values and beliefs, because there might be some adjustment needed with those. Patience and persistence is very, very important, because sexual adaptation can actually take years, right? So there's actually two parts of sexual adaptation. So the first one is about sexual rehabilitation, or what I like to call sexual optimization. So with this is that it actually begins with awareness of potential for sexual difficulties following any disruption in life. When you start sexual rehabilitation, you can focus on, first of all, gaining knowledge about sexuality and how to cope with the difficulties, communicating with your partner, how to manage the feelings of sexual inadequacy or changes with a sense of masculinity, understanding how the societal myths are actually impacting your sexuality, right, or your values, and then of course adjusting those values and beliefs as necessary, and then of course discovering new ways of supporting your sexual health or new sexual behaviors. When we think about penile rehabilitation, is that this is actually, the concept behind this is actually to begin having blood flow to help protect the health of the tissue. Like when you think about your body, when you don't exercise regularly, your body gets out of shape, right? The same with the penis. If you're not having those sexual erections, you're not having those nocturnal or sleep erections. Again, all those issues can come about when we talked about the development of venous leak, all those types of things. So it is important to do that. So what's involved with that? One of the first steps might even be just penis massage, right? So one of the things that we find is that if a man is not getting an erection, he might not want to touch the penis. Same with a partner. The erection isn't occurring, they don't want to touch penis. But by actually beginning to do the massage, you become more relaxed, more familiar, more comfortable. And if that actually helps facilitate some of the blood flow, then that's good, because that's helping to keep the tissues healthy. But it's also helping to maintain that mind-body connection. Right? Next thing that can happen is possibly the doctor might prescribe, some medications after treatment. Example might be, a low dose of a PD5 inhibitor or a pill that helps with erections, such as, say, cells 5 milligrams daily. So again, that's something that you can talk to the doctor about. The other thing is using penile injections to help create those erections, or even the vacuum erection device. Okay, so we're going to talk a little bit more about all these types of interventions. All right. So, and of course, these interventions can create erections for sexual play as well. So first off is we talk about the oral therapies. So the PD5 inhibitors, the pills. So basically what these pills do, they inhibit a certain type of enzyme in the body, so other kinds of chemicals can work together to help bring blood into the penis to create the erection. We think about, these are usually the first things that men will begin to try. They work all the same way, but what we encourage is men to actually try all of them, because you might be a better responder to one versus another. The other thing that's really important to keep in mind is where you are in your recovery, right? If you just had a prostatectomy, you're 1 month out, from your surgery, you might not be responding to these pills, because these pills definitely rely on the signals coming from those cavernosal nerves, right? Also, it's very important to first talk to your doctor to make sure there isn't any contraindication with you trying these pills, right? One example is nitro spray used for treating angina, right? If you're taking that, you don't want to combine it with these pills, because they both can lower the blood pressure to dangerous levels. The other thing is that, if you're on, say, androgen deprivation therapy, which decreases testosterone, that's another component that's really important to optimize the effectiveness of these pills. Right? Different side effects with these pills is that, you can have things like headache, there could be facial flushing, nasal stuffiness, there could be indigestion, there could be maybe visual or hearing changes. Sometimes with Cialis, men will complain of like leg spasms or back pain, right? Sometimes if you have some of these side effects over time, they might decrease, right? The other thing to think about with these pills is that Viagra, Levitra, and Staxin are actually short-acting PDE5 inhibitors. So they only stay in the body maybe 4 to 8 hours, whereas Cialis will stay in the body up to 32 hours, or sorry, 36 hours. It doesn't mean a man has erection for 36 hours. It just means that once he has arousal, that he can actually, the medication can work better with those chemicals to create those erections. And that's the other thing that's really important, is that you need to have good sexual thoughts, like arousal and sexual stimulation. John, he phones me up and he goes, Chris, I took 100 milligrams of Viagra. I went and sat in the garden and I waited. Nothing happened. So John, you need to be proactive. You need to have those sexual thoughts and sexual stimulation, but don't do it in the garden. So the next thing that we're going to talk about is the intraurethral suppository. So the suppository, the penile injections, and the vacuum erection device, they don't rely on testosterone or the cavernosal nerves, okay? It's not something to keep in mind. So with the suppository, it's a little tiny pellet about the size of a grain of rice that's actually put into the urethra by that little applicator. Some men who've actually gone through the catheter experience may not be too happy about the applicator. Basically, it's probably about, I say 30–40% successful, super expensive. It ranges between $40 to $70 per suppository. The guys in the UK love this product because they get it for free. It's not free here. The other thing is that it might not always be appropriate for all patients. For instance, if you have urinary leakage or urinary incontinence, the urine might actually push the pellet out before it actually takes effect. How this medication works, it causes relaxation of the smooth muscle inside the penis. When there's relaxation, there's an opening of those little spaces, and then once they open, that's where blood comes into the penis to create that erection. When we think about the next option is the penile injections. Penile injections, there's lots of psychological factors around this where men are really reluctant to move forward with this. But a lot of men, when they actually do move forward, they go, why haven't I done this earlier, right? Basically, again, how this medication works, very similar to the suppository, causes vasodilation inside the penis to create the erection. Usually after the injection, the erection will start to develop within 5 to 20 minutes. And the goal is having it last between 30 to 60 minutes. Does it hurt? No, a lot of men don't even feel when they put the needle into the penis. But I will say that the medications that we use for the injection therapy is called Trimix. So it's 3 different medications. One of the medications is called Prostate or Prostate, and 20% of men might experience discomfort, pain, or achiness when they inject that medication into the penis. If that's the case, then basically what we do is we alter the formulation of the Trimix, or we actually remove the Prostate from the Trimix. We actually do the training for penile injections here in the clinic. Again, it's very successful intervention, about 90% successful, creates a more natural looking erection, say compared to the vacuum erection device. And it's most economical compared to the different other interventions such as the pills, right? And yeah, so it's good. It's again a very good option. Some people ask, when can they start using it? Usually, within I would say 6 to 8 weeks after prostatectomy, with radiation, anytime that a man begins to experience erectile challenges, so it can be implemented at any time. And then the last one that we're going to talk, or not the last one, second last one we'll talk about is the vacuum erection device. So again, the vacuum erection device, there's lots of different ones that you can get. You can get them at adult love shops. You can get them at certain pharmacies. This particular one here is actually, it's actually a medically graded vacuum erection device. So what that means is that the millimeters of mercury used to create the negative pressure that draws the blood out of, into the penis is regulated. Whereas some of the vacuum erection devices and love shops, they're not. So there might not be enough negative pressure to create an erection, or there might be too much where that might suck the testicle into the vacuum erection device, right? The vacuum erection device is very successful, about 89% successful. It does take time to master this technique, right? You need to have it get a good fit against the body, a good seal. A lot of times, you would have to give yourself a haircut down there, removing some of the pubic hair for getting that good seal. But also, if you're using a tension band, it makes it easier to get the tension band off. A lot of times what we say is that, if a man was going to use this, we would encourage them to use it for 14 consecutive days to sort of recondition the tissue inside the penis, right? And then after the 14 days, then that's when you can begin to use a tension band for maintaining the erection for sexual activity. So what you can see is that the tension band is actually loaded at the end of the cylinder. Once the erection is created, the tension band is rolled off. It goes on the base of the penis, and it actually locks the blood in the shaft of the penis to maintain the erection. So a couple things about that is you don't want to leave the tension band on for more than 30 minutes, right? So you don't roll over and fall asleep. It's not a good thing. And the other thing is that what can happen is that there could be a bit of a hinge effect. So what that means is that, when the tension band is actually applied to the end of the penis, is that the blood that's in the pelvis of the penis, it might get reabsorbed. And if that gets reabsorbed, then there might be a bit of a hinge effect that happens. So if that happens, is that if you're going to be engaging in penetrative activity, what you want to do is you want to manually guide the penis wherever it's going to go, whether it's mouth, anus, vagina, sex toy, at least 50% of the way before there's actually movement, because the surrounding structures will actually support the penis before there's movement. Okay. So again, that's the information about the vacuum erection device. So if you're about 2 years after your treatment, and you've tried these different interventions and you're not satisfied with the responses, then the next option would be the penile implant. This is something that's very successful. It does require surgery. There's different types of penile implants. This is actually a common model here. It's a 3-piece model. There's a reservoir that sits in the pelvis. There's an activation mechanism that sits in the scrotal sac. And then there's special types of cylinders that replace your corpus cavernosum or the erectile bodies inside the penis. So when you want to actually have an erection, you actually compress the system that's in the scrotal sac, and that will allow saline to come down the reservoir to fill the chambers inside the penis to create the erection. And the erection will be maintained until you deactivate it with the mechanism in the scrotal sac. So the questions are, is that, can you try the implant and then go back to something else? And the question to that is no, you cannot. The other thing is that people ask, like, well, how long do they last? And basically, research is saying probably around 10 years. So you have you got good options with that. And then the other thing is cost. There's actually funding that's actually put together through the government. And the men that I've known that actually have done this is that they've actually had it covered, so there was no expense to them. So again, these are the different options to sort of think about. And basically now the question is probably, how do you begin? How do you begin? So basically you want to talk about the changes and how they make you feel. And then the other thing is you want to discuss maybe other ways how you can enjoy sexual activity. And then also, having that communication with the partner, let the partner know what feels good for you, and ask them what feels good for them as well. Again, communication, and of course, request an appointment to actually come and see a sexual health clinician at the Prostate Cancer Supportive Care Program, or even connect with our counselor or a community sex therapist. So I've talked about a lot of different things today, and on our website we actually have various videos that really complement what we've talked about. So please feel free to go to our website and kind of check into that. The other thing I want to say is, again, prostate cancer or bladder cancer treatment can impact your sexual functioning, and basically our program is here to support you as you kind of deal with the different changes that are occurring. Okay, so one of the things that I wanted to say is that, again, talking about cancer or even maybe going through this educational presentation today, it actually might stir up a lot of different emotions or thoughts that might be overwhelming or stressful. And our goal is to be able to help support you. And if you have your partner, support your partner as well. And so if you're having some of these kind of, overwhelming feelings, this is actually quite normal, right? And so what you can do is you can consider touching base with our counselor, because our counselor is there to help facilitate you navigating these different emotions, right? And with our program, you can actually have up to 6 counseling appointments. Okay, so again, if you're interested in connecting with our sexual health module or any of our modules, you can contact Jenna. Jenna's our coordinator, and she can actually help organize this. Okay, so again, thank you for your time, for kind of coming in and watching this presentation. Thank you for your patience too with me sipping my tea and things like that. And I hope everything goes well with your journey with your cancer treatments and managing of the consequences. Take care. Thank you.